Assalamu alaikum students. Once again, we are here with our pharmacology lecture. In yesterday's pharmacology lecture, we studied about the epinephrine and norepinephrine, the catecholamine synthesis. Okay, so I also discussed the functions and the localization of alpha 1, alpha 2, beta 1, and beta 2 receptors, along with the drugs that were acting on the level of presynaptic and postsynaptic neuron. Also, we studied about the MAO and the COMT. Okay, so today our main topic will be the adrenergic agonist drugs. Okay, and we all know we divide this adrenergic into two categories. One is catecholamines and the other one is non-catecholamines. So in your first state, they have not given that categorization and they have just summarized only the important things you need to know in one page. Okay, but we will take it slow, and so that you may understand it, so that when you read this page, you can get the important points really good. Okay, so I will begin my lecture with epinephrine today. Okay, not with albuterol or dobutamine. I will touch the main. First of all, I will tell you what the main neurotransmitters epinephrine and norepinephrine in our body do. Okay, and what happens when we take this epinephrine and norepinephrine synthetically. There is epi and norepi naturally present as a neurotransmitter. Okay, that is working at your neuronal ends when you are in a sympathetic response. Okay, right now you are taking the lecture and I am delivering the lecture, and we both are having the parasympathetic effect. Okay, we are under the parasympathetic effect. But let's say, for example, you hear a thudding sound outside, and suddenly you got, like you shivered, you feared, you get anxiety. So all those things, all those sudden change of feelings that make you frightened or make you in a hurry position, so that is sympathetic nervous system. So the main neurotransmitters that are dealing with them are api and norepi, but we also give epi and norepi in synthetic form. Okay, so first of all we will discuss what epi and norepi do when we give it in synthetic form. Okay, so in your book there is only this one line written about norepi. Okay, and there is this 2 or 3 lines written about epinephrine. So we will discuss it in a detailed fashion, and then we will touch the other catecholamines like dopamine, like dobutamine, like isoproterenol. We have if I talk about this chart, specifically this chart, okay, dobutamine, dopamine, epinephrine, isoproterenol, okay, and if I go a bit down, norepi, okay, these 5, because I have changed the position, so let's just like this. Okay, so dopamine, norepi, dobutamine, dopamine, epinephrine, isoproterenol, and norepinephrine. These are catecholamines. Okay, we divide catecholamines and non-catecholamines. So if I first clear all this, or let me extend this chart. Okay, and okay, now I'm just making little space so that I don't like actually shifting screens. Okay, so if I make your adrenergic agonist, and I'm only talking about the agonist drug. If I give agonist shift this agonist drugs into two, like catecholamines and non-catecholamines. Okay, catecholamines and non-catecholamines. You should know what are catecholamines. First of all, you should know the names. Okay, so epi, norepi, okay, then dopamine, then dobutamine, okay, dobutamine, and then isoproterenol. Okay, these are your catecholamines, and these all drugs are adrenergic agonist drugs, not antagonist. We are only studying agonist, which is also called mimetics, sympathomimetics. Okay, and when I talk about non-catecholamines, there are so many of them. Okay, so many, like albuterol, terbutaline, this midodrine, this mirabegron, this phenylephrine, or oxymetazoline. There are so many. Like in your, even in your first aid, they have not given all the names. But if you kind of like check your book, your main textbook of your Lippincott, in your Lippincott, the best thing is your first page of this adrenergic agonist has this list of non-catecholamines, and you can just open your book and you can see that all these names like oxymetazoline and phenylephrine given here, and mirabegron given here, or albuterol, salmeterol, terbutaline, your the ones that act on your respiratory tract, okay, or your clonidine. So all these drugs are non-catecholamines. Okay. Now let me clear this. Now another thing is you should know, like, why do we call, what is the most important point you need to know about catechol and non-catechol? Like these there is a difference between why do we call them catechol and why do we call them non-catecholamines? So if we talk about the major differences that you need to remember, okay, only those differences that you need to remember. First and foremost, this is catechol and this is non-catechol. Okay. First and foremost difference that you need to remember is catecholamines can not cross blood-brain barrier. Please remember, please, this is the first difference I'm telling you, and the most important difference you need to know in pharmacology. All catecholamines, epi, norepi, dopamine, dobutamine, isoproterenol, they cannot cross blood-brain barrier. And non-catecholamines can cross blood-brain barrier. You can write it in your books. Write it in your, the way I study, I used to stick notes in my books. I have these sticky notes, and whatever extra points I have, or make one page and just write small things and stick that into your book along there, so that your first aid is a book which you have to revise throughout your life. So when you will be revising, you will be seeing all these points which you have like studied sometime. Okay, so this is the best way to study. You do not open so many books and you do not sit with so many books. One book should be enough. Okay, so make your notes in that one book. Okay, so write this point. This is most important point. All catecholamines cannot cross blood-brain barriers, but the non-catecholamines can cross blood-brain barriers. So it means that the effects of non-catecholamines can be shown at the level of CNS. You will be studying the adverse effects on CNS of non-catecholamines. Okay, and then if I talk about number 2, the number 2 important difference you need to know regarding this non-catecholamine and catecholamines is, wait a second, okay, half-life. Please remember. Okay, half-life of both. The half-life of your catecholamines is short. Its duration of action is also short. It works quickly, and its effect wanders quickly. It start working quickly, and its effect goes off also quickly. What is half-life? We write half-life as P50. In pharmacological terms, we write it as P50. Okay, P50 is called half-life. Half-life means, for example, if your drug has a potency of to work, like if you are taking this 4 mg drug. If you are taking a drug, okay, example, I'm just giving you an example of half-life. The drug is of 4 mg. So the amount of drug that remains in your blood, okay, after distribution, when it's like distributed to several organs where it's acting, the amount of drug that is in your blood after distribution, it stays in your blood too for some time, okay, for some period of time. So let's say this is a drug whose half-life, whose dosage is 4 mg and half-life is 2 hours. So till 2 hours you will see 4 mg in your blood, but after 2 hours your drug will be 2 mg left, and the rest 2 mg will be excreted out in the form of urine or stool or whatever its pathway of excretion is. Okay, so please understand the concept of half-life. Half-life means the drug that half of the dosage of drug that remains for a certain period of time. Okay, every drug has a different half-life, like different time. Okay, so the amount of drug that you are taking, half of the amount of it stays in your blood for a certain amount of time, and after that certain amount of time it is excreted out, okay, in the form of metabolites from your urine or from your stool. So the time it remains in your blood is called half-life. The time it remains in your blood to show its action. Okay, half-life is time. Okay, so that is half-life. So your catecholamines has a short half-life, and your non-catecholamines have a longer half-life as compared to catechol. So please, this is your another point, remember it. So I told you two differences now. Okay, then there are many other, like you can, the way you give the drugs, like some drugs are given orally, some drugs are given intravenously, some drugs are given intramuscularly. So you give most of your non-catecholamines orally, but this is not important. You give your non-catecholamines also intranasally, you give them also intramuscularly, you also give them intravenously. So you don't need to remember the way we give it. Similarly, the catecholamines are given mostly IV. You give them mostly IV, but you also give them IM. But you do not give your catecholamines by orally, okay, because it has a short duration of action. Catecholamines are also considered as emergency drugs. So emergency drugs are never given orally, okay, they are always given IM or IV. Okay, please make this point clear. Catecholamines are used as emergency drugs mostly, but non-catecholamines can be given orally, IV, IM, intranasal, etc., etc. Okay, then there is a point when you give any drug in an emergency situation. For example, you are giving IV. Okay, let's say you are giving dopamine. Okay, the brand name of dopamine is Serenase. Okay, this is the brand name of dopamine, Serenase. You are giving a patient dopamine IV. So how, like, you will give it? You will just take the injection and just put it in his vein and done? No, no. You give it in a continuous infusion. continuous infusion. When you will be working in the hospital, you will be, these points you have to only remember. Now, whenever a doctor will only, your senior doctor will only write Serenase, okay, this time of the day, this dosage. Now you are the duty doctor. What you should be aware that this is a catecholamine and you have to give this drug in a continuous infusion. How you give a drug in a continuous infusion? Let's say this is your bag of normal saline, okay, 0.9%. 0.9% is a isotonic normal saline. You inject your dopamine into a certain amount of normal saline. Let's say it is 500 ml. You mix your dosage of drug into this 500 ml of normal saline and you give this infusion, this continuous infusion to the patient. Okay, this is how you will give. This is called continuous infusion. Okay, but then there are drugs that you give in slow infusions. There are drugs that you give like 2 times a day, 3 times a day. So when we talk about fixed dosages, catecholamines do not lie in this category. We never give fixed dosages in case of catecholamines. Why? Because they are emergency drugs. So just from one word, emergency, how many things you can remember? Number one, emergency drugs, duration of action should be shorter. Emergency drugs, half-life should be shorter because we want quick effects. Okay, we want quick effects. Emergency drugs are never given orally. You give this IV, you give it IM. Okay, emergency drugs do not have fixed dosages. Why? Because they are emergency. You are giving it 1 time or 2 times. You are not giving, you can give it like any time, but in the case of emergency, when it's needed. You do not write a prescription of dopamine IV to a patient. You do not write a prescription of epinephrine 3 times a day to a patient. You don't do this. Never do this. Okay. And when we talk about that these emergency drugs are given in infusion format, you should know what the word continuous infusion means. Okay. So up till now, you have understood that what is the difference between a catecholamine and not non-catecholamine in terms of half-life, in terms of infusion dosages, in terms of duration of action, and in terms of the most important, can cross blood-brain barrier and cannot cross blood-brain barrier. So which is the one that cannot cross is catechols. Okay, the emergency drugs do not cross blood-brain barrier. These emergency drugs, not all emergency drugs, these emergency drugs. Okay, but the non-catechol can cross blood-brain barrier. Okay, so please remember these little things, very important. Okay. Another thing I want to tell you is, do you remember we studied MAO and CUMT? What MAO and CUMT were doing? MAO and CUMT were metabolizing. Okay, they were, I showed you that we have this epi and we have this norepi. Then epi was converted to metanephrine, norepi was converted to normetanephrine. This is the previous lecture, yesterday's lecture. Okay, and then both of them were converted into VMA, that is vanillyl mandelic acid. Okay, and this VMA, this metanephrine, this normetanephrine, all were excreted in urine as inactive metabolites. I explained you this yesterday. Okay, so all of these inactive metabolites are produced from MAO and CUMT. At some places MAO were acting, at some places CUMT were acting. Okay, and I told you the location of MAO and CUMT. If you remember yesterday's lecture, I told you that MAO and CUMT both are present in your gastrointestinal gut wall lining. It is present in your intestinal gut wall lining. So when we say it is present in an intestinal gut wall lining, it means the drug that you are taking orally, okay, the drug that is going through first pass hepatic metabolism, it will degenerate this. Okay, so the drug which you are taking orally can be metabolized via MAO and QMT, and the drug which you are not taking orally, let's say the catecholamines, which are emergency drugs, you are taking them IV or IM, they cannot be metabolized by MAO or QMT. You will not see these metabolites. Please remember this concept. Very important concept. Okay. That is the reason you do not give these drugs orally as well. Okay. Because if you will give them orally, they will be metabolized quickly. Okay. So you never give catecholamines as oral medication. So now, when you are clear with the concept of this, let's begin epinephrine in detail. Okay. When we talk about epinephrine, we have a lot to discuss and understand. Okay, so if you won't mind, I want to stop sharing this screen, and I will take you to this whiteboard. Okay, because your first aid do not have much in it, so I kind of want to write it. Okay, and you can also make your notes. So when we talk about epi, the first things first, it is a catecholamine. Its duration of action is short. Okay, and its onset, which we say, is rapid. Okay, onset is rapid and duration of action is short. The most important thing, it works on alpha 1, alpha 2, beta 1, beta 2. If I will talk about norepi, norepi works on alpha 1, alpha 2, beta 2, not beta 1. Or I think it, if I'm mistaking, it works on beta 1, not beta 2. Wait a second. Huh? So let me, I should not make mistake over here. Yes, it doesn't work on beta 2, it works on beta 1. Okay, so you will not be seeing beta 2 effects here. No beta 2 effects in norepi case, but you will see beta 2 effects in epinephrine case. So this is a difference, and this is a very important difference. Okay, so we will be seeing the therapeutic uses and actions of this epinephrine drug on all these 4 receptors. Okay, so now let's see on its actions. Okay, please remember, you are giving a drug in low doses and you are giving a drug in high doses. These are your MCQ points. Okay, when you will understand, when you will learn this, if they will give you a case scenario, you can understand what effects epinephrine will have. If you are giving a high dose of epinephrine, okay, you will see alpha effects more than beta effects. Okay, alpha effects more than beta effects in high doses. But when you give low doses, you see beta effects more than alpha effects. Okay, please remember, high doses alpha effects, low doses beta effects. You have to learn this. Okay, so when you are giving a patient low doses, the effects will be more on beta 1 and beta 2. When you are giving epinephrine in high doses, the effect will be more on alpha 1 and alpha 2. Okay, so now when we talk about effects, let's talk about CVS first, like the cardiovascular system. Okay, We all know that epinephrine is a sympathetic nervous system neurotransmitter, so the drug will also show the same thing, same actions. Okay, so it will increase the heart rate, it will increase the cardiac output. Okay, it will increase the total peripheral resistance. Okay, but how are these things going on? Okay, so if you remember, I told you in the previous lecture, we have this beta 1 receptors on the kidney. Okay, on the kidney we have this beta 1 receptors, and kidney releases renin. So we have this RAS system activated now. The final product of RAS is renin angiotensin aldosterone system. So the final product is aldosterone. And I told you yesterday, one of the functions of aldosterone is vasoconstriction. Aldosterone is a potent vasoconstrictor. That means very highly, it shows its actions, a potent vasoconstrictor. So when your blood vessel lining will be constricted, the blood will apply pressure to the walls. When the blood will apply pressure to the walls, the total peripheral resistance will increase. When the total peripheral resistance will increase, the systolic blood pressure will increase. Systolic blood pressure is the contraction. Okay, the contraction when your heart contracts and the blood is pushed from your left ventricle to the body, to the aorta, and then to the arteries, to different organs. It is a contracting pressure. And the diastolic blood pressure is the relaxing pressure. Okay, so when your total peripheral resistance, whenever your total peripheral resistance is increased, your systolic blood pressure is also increased. Okay, but the beauty of your epinephrine is it decreases the diastolic blood pressure, and this comes in your MCQ. How it decreases the, how, if systolic blood pressure is rising, why diastolic blood pressure is not? This is a question. Okay, so let's see how it works. I'm clearing this picture. Okay, okay, you have this alpha 1 effect, you have this beta 2 effect. Okay, when we talk about alpha 1 effect, alpha 1, the blood vessels constrict. But when we talk about beta 2 effect, the vessels dilate. And epi has both alpha and beta. We are not talking about the doses right now. Okay, we are just talking in general. Yes, we can take a break of Maghrib namaz. Actually मेरे पास नहीं हुई है, but आपके पास हो गई है, so we can continue our lecture at 7:15 or 20, or you can message me on WhatsApp. Okay, so we will continue. No problem. Okay, so I am like stopping the recording. Okay, so that it should be saved. The time should be saved.